And what I can say is, to this, I mean, we are at our center, very aggressive with transfusion.
Yeah, now we have changed.
And if I have patients with hemoglobins of 8.5, and you know, the thalassemia intermediates, especially the ones with hemoglobins in a range where they can function, like I'm going to say 8.5 to 10, maybe 10 can make it without maybe. These are the most difficult patients to manage. These are the patients where you want to talk to your colleagues, and your colleagues that have much more, I mean, you know, in the United States, you know, we think that, you know, we have experience in Los Angeles because we've got a couple hundred thal patients, but in Italy and Greece, and you know, I always remember a meeting I was at with Dr. Foucheron, and he said, "How many patients do you have?" And I said, "Well, you know, I've got 150, and how many do you have?" "Well, I have 5,000. So our experience in this, but anything in medicine, it's clinical experience. How many have you seen? And so the thal intermediates are the hardest people because you really need this clinical experience. We started transfusing now. We have many patients that we put on transfusions with hemoglobins of 8, and what's striking to us is these kids, these children, do clinically so much better. And they don't get the ineffective erythropoiesis, they don't have the bone changes, and I remember so many times looking at serial photographs at Christmas trying to decide are bone changes happening, and it's these are very difficult. These patients really must be seen by somebody who's seen a lot of these patients.
I heard
very
a chorus
difficult.
from this side of the table. It was a yes?
Yes, so in the past, we might have been more reluctant to be aggressive with transfusions because of the HIV, because of the ineffective chelation regimens that we had. Now, we don't worry about that so much. So we are far more aggressive in terms of transfusing them and maintaining normal growth, normal development, normal activity levels. You know, they go to school, they do all of these things just fine.
So I come back to, it depends. If your hemoglobin is happy and you can stretch out the transfusions. If somebody's running a hemoglobin, okay, tell me where I'm wrong. So supposing I've got somebody with a hemoglobin of 9.
Well, even though the hemoglobin is 9 and they can function, there's still underlying ineffective erythropoiesis and damage that is going on that'll catch up to them over time.
Where would you
so you want to stop that.
Let me put it this way. Where would you not transfuse somebody?
No, exactly. I mean, what is driving the decision of transfusion, I should say that it's not the level of hemoglobin.
Okay.
It's
That's
not
what
the
I'm missing.
level of hemoglobin, but is the clinical behavior of the patients, which means is a child, is not growing well, has problem to play or to go at school compared to his or her peers. So all this, the bone phase, the bone change are appearing. So why waiting to have adult non-transfusion dependent patient with all the consequences she mentioned? So that, I conclude saying that really we need to be aware on how much ineffective erythropoiesis is playing a role.
So the hemoglobin level can be maintained, but at a cost. So if you have a hemoglobin of 9, but your marrow is working really, really hard, and you have extramedullary hematopoiesis, now that's somebody who needs transfusion. But if you're 9 and you have no hepatosplenomegaly and you have a very minimal amount of ineffective erythropoiesis, you may be able to get by without transfusion.
So the marker is not, again, you'll forgive me, not the hemoglobin.
Right.
It's what's going on with the fat.
Everything else.
The problem is when you see these changes, you see the bone changes, you see the big liver, and that tells you that this process has been going on for a long time. And so again, we come back to this point of we're trying to suppress the marrow activity. So the decision, and I'll see it's do you need to be on transfusions chronically, yes or no? If the answer is yes, then we put you on regular transfusions every 3 weeks or every 4 weeks.
So it doesn't depend on the hemoglobin, it depends on the clinical presentation.
Whenever the hemoglobin is dropping below this level, the marrow is turning back on again.
But it's the bone marrow of thalassemia, because I ask you a question. If you have a lady with 8 grams of hemoglobin just because she has no iron. She is iron deficient. Are you going to transfuse her?
Probably not.
No.
Depending on what her comorbidities are.
You're giving iron because her bone marrow is not ineffective. It doesn't have iron to produce hemoglobin. So it is a different mechanism of pathophysiological mechanism.
One thing I sort of feel compelled to bring up, and that's, we showed a year or two ago that the brain white matter volume is linearly inversely correlated to the hemoglobin. And so if you're anemic, I think that we know that the thalassemia intermediate patients, for example, have a higher risk of, have a higher incidence of silent strokes. Okay. And so I think globally we're going to have to rethink these anemia standards, because anemia itself is not good. I personally don't think it's okay to have a hemoglobin of 8, even if it's from iron deficiency.